Now I invite Dr. Vivek Gupta, who is the consultant cardiac anesthetist from Hero DNC Heart Institute, Ludhiana, uh, to talk on ECMO in other conditions, sepsis, hypothermia, drowning, and poisoning. He has a special area of interest in ECMO and toxicology. Welcome, sir.
Thank you, sir. Thanks for the kind introduction. First of all, I'm thankful to the organizing committee, especially Dr. Suresh Rao, for giving me this opportunity to speak on such an important topic, especially the poisoning, which is core to my heart. Basically, in last 10 to 15 years, there is after the H1N1 pandemic, the interest in the ECMO has increased, and now the intensive care specialist and the emergency physicians, they are looking for the various indications, new indications, and more use of the ECMO. So if we talk about the sepsis, initially sepsis was used to be a contraindication because we were worried that possibly a cannula circuit will disseminate the bacteremia. There is a foreign membrane which further increase the inflammatory response, or the coagulation issues which are already with the sepsis can be worsened. But in the initial reports in 1990, they showed that ECMO can be successfully used in the septic patients, and they used VA ECMO, and VV ECMO was restricted only for those patients who had a ARDS, sepsis-induced ARDS. So to understand the use of ECMO actually, we should first understand that which phase of the myocardial dysfunction is. Because we know that in the early phase, it's the low flow state where we give fluid, patient is relatively hypovolemic because of the leaky capillaries. So we give fluid and we maintain the stroke volume and hemodynamics, and we just by volume expansion, we maintain the patient. In the second phase again, the cardiac output further increases, and there is a low systemic vascular resistance. And this is the phase where we need vasoconstrictor to maintain the hemodynamics. And this is the third phase actually, which is important from ECMO point of view, that when there is a decreased cardiac output and SVR is rising, and because of this poor tissue perfusion, worsening of the lactic and metabolic acidosis. Probably this is the ideal situation when a person can be considered for ECMO. Because we know that in sepsis is, even when the heart function is normal, still there is a certain amount of worsening of the myocardial performance in the initial phases. And gradually, the diastolic dysfunction, and after day 3, LV systolic dysfunction, if it further worsens, even associated with ARDS, are separately also there can be an association of RV dysfunction as well. So what exactly ECMO will help us? It will give a temporary cardiovascular support. It will support the lung as well in case of ARDS. And by maintaining the hemodynamics and tissue perfusion, temporary renal support, and definitely dilution of cytokines, and it can give us a platform for other therapies as well. So which type of ECMO? This is very important to understand. Now we have diagnosed that the patient is in the septic shock, and we have done an echo. On the basis of echo, I'm seeing that patient is having a LV failure. So if there is LV failure, peripheral VA ECMO is a method of choice at the moment. But if suppose this patient worsens and develops a severe ARDS, now we can switch over always to a VA-V ECMO. If the patient is having ARDS, along with that he is having RV failure, we try to maintain this patient optimized on VV ECMO. But if the RV failure is persisting, then probably a VV ECMO will be a good option in these patients. But those patients who have a normal ejection fraction are having the hyperkinetic myocardium, then possibly these are not the candidate truly speaking. But if at all, if we are thinking, because they need a very high volume to maintain their perfusion, so possibly central coagulation can be an option, but still it is very early to say. If we talk about the newborn sepsis, ECMO has been considered by American College of Critical Care Medicine as a last resort in cases of refractory shock. Similarly, in cases of infant and child sepsis also, they have considered if the child is resistant to the catecholamine, not responding to it, then possibly a ECMO can be an option. But for the adult, still there was no clear-cut guidelines that when to start or how to start. So initial reports are a bit encouraging. The first paper was, one paper was published in 2013, where they had taken the 14 cases where none of them had the cardiac arrest, and they had the ejection fraction of nearly 16% with a low cardiac index and increasing filling pressure with the myocardial depression. and they found that 10 out of 14 were they were able to discharge. Only 2 deaths were on the ECMO and 2 were in the ICU. Another paper which was published recently in the Lancet, and this was basically a retrospective multi-center international cohort study where they took the 82 patients and all received the VA ECMO in the 5 different centers, and all patients had the severe myocardial dysfunction with the cardiac index of less than 3, ejection fraction was less than 35, and the VIS score was more than 75. In fact, ECMO group was worsened than the comparable group, and they found that the ECMO patient did better, and their survival rate was much better as compared to the non-ECMO group. Another this paper was published recently in the Critical Care in 2021, where they searched the database from the different PubMed, Scopus, and Cochrane database, and they took all cases where they were including the 5 adult patients or more who had undergone the ECMO, and they found the 14 observational studies with the 468 patients, and they found that the survival was better when the patients were put on ECMO as compared to the non-ECMO group. So this is the data is encouraging, and but we have to select these patients rightly, that which patient has to be given which therapy. If a patient is having a right heart failure or ARDS, probably a VV is a good option. If the patient is having a left heart failure, VA, when to switch to a VAV or VVA, that we have to address depending upon the patient condition. Then possibly if there is a distributive shock, theoretically central VA ECMO may be an option, but how much flow is required, no one knows. So there are certain unanswered questions that which patient will be benefited. Possibly patient with a severe LV dysfunction will be benefited, and we should avoid ECMO in the distributive shock. Combining ECMO with other adjunct therapy like we are using high volume filters, cytosorb other, we don't know that how much it is affecting the outcome. How much ECMO flow, how much flow is required, especially in the distributive shock, whether the central VA ECMO is better or not, it is difficult to say. What is the optimal level of anticoagulation, especially in those patients who are developing a DIC? And any colonization issue, still we are not clear that whether it is affecting the outcome of the patient or not, it is difficult to say. So these are the things. Next, coming to the accidental hypothermia. We all know that accidental hypothermia, when the core temperature goes below 35, and usually the patient will develop arrhythmias and patient will collapse if it goes below 28, and will have a deleterious effect and a very high mortality risk. The incidence, usually it is underestimated, we can understand, because it's difficult to diagnose it and reach to a place where a person is hypothermic. These patients can be our avalanche victims, are the mountaineers. Usually these are young people with no underlying diseases. The other class of the patient will maybe urban population, especially those countries, cold countries, which are intoxicated with alcohol or other drugs, and they suffer with the comorbidities as well. So this is the 2 different extremes of the patient. And third is the drowning victim, which are at a primary risk of hypoxia, asphyxia. So there is a staging system also. That's a switch staging system for the hypothermia in the pre-hospital setting, so that we can choose these patients, that which patient should be categorized for the putting the patient on ECMO. So what are the indications? The 2 clear-cut indications which we can find in the literature is the hypothermia grade 3, when the patient is having a hemodynamic instability and possibly having arrhythmia, and when the core body temperature is less than 28. And the second one, if the person is having a hypothermic cardiac arrest. These are the 2 standard indications for ECLS. So which ECLS? Because if you search the literature, you will find that some people have put the patient on cardiopulmonary bypass, some are using other modalities, but the gold standard is the VA ECMO, because it has a rapid availability, we can put it very quickly, low heparin is required, so bleeding risk which is very common in these patients, it can be reduced, and if the support is required for a longer time, it is very easy to continue it. And moreover, besides rewarming, it is going to give us a cardiorespiratory support as well. So there is a algorithmic approach that how these patient has to be managed, because once you find that a patient is severely hypothermic and the outreach team has identified these patients, there should be good communication between these team leader along with the emergency department team leader. So time is really crucial, and their communication is very crucial. The rapid transport with the whatever possible air ambulances has to reach to the hospital, and CPR has to be continued if the patient is having cardiac arrest, and depending upon how the patient is. If the patient is not having any trauma, the patient should be taken immediately to the OT. If ongoing CPR is there, then possibly you don't have a time and you should move towards the OT and do a trauma assessment in the OT itself. And side by side, the surgical team continue putting the cannula, arterial cannula, and the process, then you make a decision whether we have to go for ECMO in these patients or not by choosing other parameters as well. So for that, the core temperature should be less than 28 and the potassium level should be less than 12. If it is more than 12, then possibly it has set in and there is a least chance of recovery. So this can be taken as a decision for stopping the CPR in these patients. If the patient is having a severe trauma, suppose the patient is having a free fluid in the abdominal cavity or the pericardium, so it means probably a trauma is the more damaging and possibly there is a least chance of recovery. So the different challenges which we can come across in these patients, because these patients are severely hypothermic, so it is very difficult to distinguish that whether it's a death or a patient is severely hypothermic. And especially for those staff who are in the pre-hospital area, it is difficult for them to identify this. The complexity of situation, because trauma and asphyxia in these patients are common and it is very difficult to differentiate which is actually a cause of deterioration of these patients. Then if you have a more than one patient, then choosing a right patient that which has to be put on the ECLS and which to be avoid, this decision is very difficult to make. And a coordination, because it has the multidisciplinary approach, the coordination amongst the all team, outreach team, transport team, along with the emergency department operation room is very, very important, and definitely it's a costly affair. So how to prognosticate this? There is a scoring system for these patients. That's a HOPE score, which considers the age, gender, asphyxia, CPR duration, serum potassium levels and temperature. It is a calculator basically, and we can look at online that we can calculate and find out that what is the possibility of survival of this patient. The predictor of poor outcomes are high rewarming rate if you do it very fast, because usually with the ECMO machine, RCP machine, you can make it 6 degree centigrade per hour, but you have to be careful because if you do it very fast, there can be several edema and other issues, asphyxiation and high serum potassium level. So we don't know, by hemodilution, we can definitely improve the perfusion, but this leads to a microvascular extravasation as well. And compartment syndrome, and patient may have a several edema. What should be the priming volume solution? Whether it's a crystalloid or colloid, still we need to answer this. And initiation site, whether it should be OT or emergency department, or even at the site of identification of the hypothermia. This is again, it is difficult to say that which can have a better outcome. And what should be the rewarming strategy in these patients, because these are the different stream of the patient, urban populations and those patients who are on the mountains. So how fast their rewarming should be done. But a recent paper has definitely showed at a slow rewarming with the hypothermia post-resuscitation is associated with a better outcome. Drowning, again, these patients, those are the candidate for ECLS who are unresponsive to the conventional therapy and where the prolonged CPR has been done. VECMO in patients who have a cardiovascular collapse, and these patients can develop ARDS as well. So for respiratory support, sometimes they are needed with a VECMO. The early initiation has shown a better results and better outcome in these patients. Coming on the poisoning, you have 3 categories of poisons. If you look at the literature: drug and healthcare product, chemical used for agriculture industry, and plant and animal toxins. So if you look at the drugs, what are the drugs? These are basically those drugs which are having a membrane stabilizing activity, like antiarrhythmic class 1, beta blockers, antidepressants, antiepileptics, other drugs. They can be a severely cardiotoxic drug where there can be a cardiovascular collapse. The other class, chemicals, insecticides, fungicide, pesticides, these all can be used as a poison for self-harm or even some of the accidental poison. But one thing across the world is very common, that these are the younger population. All these patients ranges from 20 to 50 years. But the type of toxins which are used or which are accidentally taken are the analgesics, cardiotoxic drug in the Western countries, whereas in India, it is more of the pesticides or sedative drugs which are commonly being taken. So basic principle remains the same: initial resuscitation, removal of the toxins, and prevention of re-exposure and administration of antidote. But sometimes it is not effective because patient is reaching at a different time, and there can be a life-threatening overdose where these measures are not effective. And that's the time when an ECMO is needed in these patients. So why these patients die because of poisoning? This is basically a primary insult because of hemodynamic instability or collapse, respiratory arrest. Secondary insult is associated with the metabolic derangements or electrolyte imbalances, acid-base disorders, or arrhythmias, are drugs, inotropic supports, or antiarrhythmic agents which we use to manage these patients can lead to myocardial depression and arrhythmias. Along with that, duration, quantity, and severity of toxins and comorbid conditions are also play an important role for these poisoning patients. So why we can use ECMO in these patients? Basically, most of these deaths because of poisons can be because of cardiovascular collapse. But these are reversible because once the toxin is out, patient can improve. Because most of these patients are young and healthy. So ECMO help in maintaining the tissue perfusion and help improve the cardiac output, so the metabolism of the drug also takes place very quickly and allow us a time for hemodialysis or hemoperfusion. So it can be used as a bridge to recovery, bridge to antidote, bridge to elimination of toxin, and bridge to transplant. Both VECMO and VVECMO can be helpful depending upon what type of toxin has been taken. The contraindications remains the same as we do for other ECMO procedures. But remember, all poisonings cannot be treated, like a cyanide, hydrogen sulfide, sodium nitrite, and especially if the patient is having a vasodilatory collapse, ECMO will not be helpful. I'll not go in detail of these studies. There are very few studies available in the literature where they have used the ECMO for the different kinds of drugs, especially the cardiotoxic drugs, and have shown a good survival. In Indian scenario, we have a study from our own center where we have done nearly 100 ECMOs for the aluminum phosphide poisoning, and we have a survival of nearly 65 to 70%, and all the patients are on follow-up, and except one patient who committed suicide afterwards, all the patients are having a normal functional life, though they are on their follow-up there of the psychiatrist. So we propose an algorithm for these patients who are severely intoxicated. If the patient is hemodynamically unstable, in spite of good fluid resuscitation, vasopressor, and inotropes, we have to look at whether antidote is available or not. If no, or even if patient is unstable and there is signs of clinical deterioration by looking at echocardiography, blood gases, then we have to decide that whether this patient is candidate for ECMO or not. So if there is a persistent cardiac arrest or there is a refractory cardiac failure, we have to look for an outcome, that what outcome we are looking for, whether it's a bridge to recovery, antidote, renal replacement therapy, or transplant. Depending upon the outcome, we should select these patients for ECMO. Similarly, for VV-ECMO also, we have to look for after increasing the ventilatory support, if patient is not responding and cardiac function is normal, or we understand that this is because of hypoxemia, we can initiate the VV-ECMO, and if any times patient's cardiac function worsens, we can switch over to the VV-ECMO or VAV-ECMO. So to conclude, the use of ECMO is increasing in last 10 years. We are looking for the different new indications. Because of better understanding of ECMO physiology, our experience and advancement in technology, it can be useful in the various life-threatening conditions. But it is very important that we select a patient and start ECMO at right time. Though the initial results are encouraging, but we need to look for some certain unanswered question in all the special category of